Good afternoon, everybody. It's a real pleasure to welcome you to this symposium on medicines and women's health across the life course. So a big welcome to our audience here in person in Liverpool and also those who are joining us online via the live stream. Thank you also to all of our sponsors, and we hope you have taken some time to meet the exhibitors already during the refreshment break, but please do go down and say hi. My name's Zecharia. I'm Director of Policy at the British Pharmacological Society and my co-chair.
And I'm Sheuli Porkess. I'm a pharmaceutical physician and Vice President of the Faculty of Pharmaceutical Medicine.
So we wanted to start off by letting you know that this symposium was actually part of the commissioned track by the British Pharmacological Society. It's part of delivering our vision for inclusive pharmacology. We believe that pharmacology must be for all the people who need the benefit, and that's currently not true for women. So the Women's Health Strategy for England, for example, that was published in July this year, begins with saying that women, as 51% of the population, face obstacles when it comes to getting the care they need. And we know that there are research and data gaps for women. So this session continued to develop as a partnership between the Society and between the Faculty of Pharmaceutical Medicine. Women's health is a priority for both of our organisations. And actually what that means for us is this session doesn't stop for us as chairs. We're going to be listening to our speakers, to all the questions that come up in the audience, and anything you want to follow up with us afterwards as we kind of take the next steps in terms of what this collaboration looks for us. And actually, part of saying that is this is a massive area. We cannot possibly cover all the dimensions of women's health in this short symposium, but we really hope it's going to be a jumping off point to start that conversation, to kick that collaboration off. And one of the things that I did want to say is it's really important to us when we talk about women's health that we want to be inclusive for transgender and non-binary people. We understand it's a work in progress for our organisations, but it's important to us to be explicit about that in this session. So, welcome to our excellent speakers. We hope you agree this is going to be a good session. The format we're going to go with is each speaker is going to talk for about 15 minutes. We're going to take chair's prerogatives for the interest of timing, imposing our own question, one question after each speaker. The speakers are going to join us back here on the stage. We're going to open to a panel discussion and then just ask you to save up all your excellent questions to the end, and we'll open up to the audience and also to those who are online who can submit questions via the app. So I think that's everything, and I'll hand over to Sheuli to introduce our first speaker.
Thank you very much, Anna. And I'm delighted to welcome our first speaker, Dr. Allyah Abbas-Hanif, who's a consultant in pharmaceutical medicine and a specialist doctor in cardiology and general practice. Alia has an active interest in maternal and women's health and is currently head of clinical development at Mhra, and also an honorary senior clinical lecturer in the Department of Primary Care and Public Health at Imperial College London, as well as chairing a number of committees looking at women's health across the system. So really delighted to welcome Alia to talk to us about the urgent need for safe, effective and accessible medicines in pregnancy. Thank you.
Thank you very much, Sheuli. And good afternoon, everybody. It's a real pleasure to be here with you today to talk about medicines development in pregnancy. And I'll particularly be shining a spotlight on a policy report called Healthy Mum, Healthy Baby, Healthy Future, which was launched in the Houses of Parliament in May 2022. So why is women's health so important? On the broader perspective, women's health is global health. But if I step back and look at my own personal reflections, these two are probably my reason for being involved in this area. So I had pandemic twins, these two, Sammy and Sophia. And as soon as I found out I was pregnant, my life pretty much changed. I looked at everything with different glasses. You know, I assessed risk in a different manner. Everything I ate, you know, I questioned everywhere I went. I questioned, did I really need to be there? And was there anything that was going to cause harm to my babies? My husband actually took it a little bit too far, and as soon as we found out we were pregnant, he locked up my bike so I could no longer cycle to work. But again, it was all about de-risking, not getting involved in any additional challenges. So when I ended up in hospital with hyperemesis and faced taking medications I'd actively prescribed to other women in pregnancy, it was actually a whole different mindset, a whole different ball game altogether. But going back to that broader picture, the health of moms in that 9 months, in that very short space of time, actually reflects and can impact generational health. And I think this quote by Professor Graham Burton, who's a retired professor of reproductive physiology at Cambridge, is actually really eloquently put, much better than I'd be able to put it. But he says, "My risk of having heart disease depends partly on my lifestyle now, but also on the quality of the embryo from which I grew. And the quality of that embryo was determined when my mother was in utero herself, and she was born in 1922. So that's 100 years of impact that pregnancy has had." Essentially, pregnancy offers a unique window during which the health and the well-being of our future and future generations is being laid down. So I'm going to now talk a little bit about the population I'd like to improve drug development for. And this does become a bit of a busy slide, but I hope it illustrates some key points. So in terms of the global impact of pregnancy complications, 800 women die every single day across the globe because of pregnancy complications. That works out to about 300,000 women globally in a year. The impact is also severe on the neonate, the newborn baby, with 7,000 newborns dying every day. 5,500 babies are stillborn. That equates to about 3 million deaths in a year globally. And most of these complications are down to a handful of obstetric conditions: preeclampsia, preterm labor, prematurity, hemorrhages, infections. A lot of this is preventable if we identify risks properly and if we had the tools in our medicines kit. The face of pregnancy is very much changing. The way a pregnant woman looks in the UK has shifted. Maternal age at having her first child is now older. In fact, the age is now 31 in the UK. There's also increasing levels of pre-existing disease as those years edge higher. And having a baby older is a good thing in terms of hopefully you're more financially sound, psychologically robust, but it does increase levels of things such as hypertension, diabetes driven by obesity, autoimmune disease, asthma. All of these have daily medications. And we've also noted that unplanned pregnancy rates are quite high. Globally, they are at 45%, and this is in the UK and across the world. And this increased during the pandemic as access to contraception and emergency contraception became difficult, and is actually described as an unseen crisis. The reason I highlight unplanned or unintended pregnancies is often there's unintended fetal exposure to medications during that critical early few weeks where embryogenesis is occurring. And we have actual data to show how many women are actually taking medications during pregnancy. 80% of women take an over-the-counter or prescribed medication. 60% of women take a prescribed medication during pregnancy. So this is not a one-off. This is becoming more and more a commonplace entity. 98% of licensed medications, though, in their SMPC or their label, don't have adequate information for clinicians to make a risk-benefit assessment for the patients, something that we don't see in other areas. So poor health in pregnancy can lead to long-term health outcomes that are negative for both mom, baby, and future generations. But we've seen little change in terms of medical management of these obstetric conditions. In fact, we've only got 2 drugs that are bespoke to obstetrics that have been developed in the last 40 years, atisaban and carbetocin. So they're both oxytocin kind of derivatives, an antagonist and an agonist for preterm labor and postpartum hemorrhage. Why is this the case? Why has there been a drug drought in pregnancy? Well, it's probably down to the long shadow that's been cast by thalidomide. Thalidomide was first used in Germany in 1957, and it was actually used as an alternative to barbiturates, a sedative, a safe sedative. And it was quickly discovered that it could be used as an antiemetic and propagated into use in young women in pregnancy. And it was marketed in 46 countries as being safe. You can see this advert here of this little toddler who's climbed up to the medicines cabinet, picked up his Distovil, and the strapline is that it's safe. However, there were no studies in pregnancy. There were no animal studies in pregnant models either. And they were just allowed to do this. And soon clusters of thalidomide abnormalities, skeletal abnormalities, and embryopathy were noted. Quickly after this, though, the birth of pharmacovigilance and the drug development processes that we now work with, and we know the rigors of developed. So in 1962, the FDA moved towards the Drug Efficacy Amendment, which meant that you had to prove effectiveness and safety in the pre-approval space, and adverts had to be accurate in terms of how they described side effects. Unfortunately, women were pretty much removed from these protections and moved to the space that they were no longer really able to take part in clinical trials. And this was women as a whole. Only in the 90s did that kind of change. And there are certain elements which are specific to pregnancy drug development in ICH guidelines. DART studies are very good, but unfortunately they often happen late. And most of the evidence that we generate in terms of pharmacovigilance is off the back of post-marketing observational studies. They have merits, they're longitudinal, they're prospective, we can work out exposure and outcomes, but the negatives are there are no controls. They're expensive in time and cost, and they're short-term follow-up. So they are not perfect. And we've seen the impact of delayed data in the way that it's hit pregnant women during the COVID-19 pandemic. This is an old slide of mine because we don't have full data with the Omicron variant. But essentially, with each wave of the pandemic and even with the availability of vaccines, there were more and more pregnant women dying, more and more pregnant women ending up in ITUs, having to be on ECMO, ventilation, craziness that we just never saw before. In fact, 40 women have died from COVID-19 in the UK. Our normal maternal mortality rate is 70 in a year. One of the good things, I guess, on the back of this is there has been a significant call to arms. You can see a report by the MHRA on sodium valproate and looking very closely at that. There's been the Women's Health Strategy, which has just recently come out with Leslie Reagan at the helm, and also the report that I mentioned, Healthy Mum, Healthy Baby, Healthy Future, which was led by, I was commissioner for, and was led by a team at University of Birmingham. That report was created and styled in a kind of Chatham House effect where we had expert witnesses of the great and the good. We had June Rain from the MHRA, we had Sabine Strauss from PRAC at EMA, so, really big personalities joining in on the conversation. And these are the outcomes of the Healthy Mum, Healthy Baby report. It's written in very simplistic language so everybody can get on board. It's aimed at policymakers and government for the first time. And I'm going to break down some of the nuts and bolts of those recommendations, but add some flesh to the bones. One of the biggest highlights for me personally that I've been working on and with lots of teams across the world is we now have an endorsement which occurred at the ICH Assembly in June of this year in Athens, where a working group will actually be working on ICH efficacy guidelines on the inclusion of pregnant and breastfeeding individuals in clinical trials, which is huge. Huge steps have occurred. But this is going to be a long process. It's probably going to take about 3 to 5 years for this guideline to come about. But that provides a great runway for us to prime drug companies and sponsors, produce better basic research for funders to get involved in this area. The other idea that regulators have discussed and has pros and cons is this idea of obstetric investigational plans or maternity investigational plans. Now, there are definitely pros to that because it means every drug potentially could have some thinking in terms of pregnancy, but these kind of things can stifle a growth of companies, and we've seen that with PIPs, which are very much European-centric. Preclinical to clinical processes, we need to improve how we run clinical trials and the complexity in pregnancy. One of the things that we've seen is often the slow recruitment of getting these patients from fairly rare diseases like preeclampsia. So how do you get them into studies in a time-efficient manner? So that would probably be clinical trial networks. Creating target product profiles for key obstetric conditions is happening. In terms of the preclinical space, is there a better way to understand MTD, maximal tolerated dose? Can we use things that are more at play at the moment rather than traditional 3x3 approaches in dosing? Can we use physiological-based PK models? Can we use machine learning to understand drug targets and toxicity? Pharmacovigilance. One of the recommendations that I was very much for in the report is updating labels with accurate information. Drug companies have this. We have it as well in terms of if you go to UK TIS, if you open the BNF, if you do a Google search, but it's not made its way into the legal document that is the SMPC and the drug label, and it should be there. And that would be quite a quick changeover. So hopefully that will happen. And because pharmacovigilance is so complicated, there are various groups working specifically on that in pregnancy. Finally, probably something that I should have kind of hammered home a lot more is the importance of advocacy. Women, young women and men both need to know that pregnancy drug development is an issue. They need to know before they get into pregnancy that there isn't a lot out there and it needs to be improved. And the only way to do that is at the grassroots level. And we've seen that with the menopause and the public getting behind and really understanding a problem. Investment into basic research really needs to occur. Pregnancy drug development is actually been described as a Cinderella area of research because it's had such insignificant, actually 2% of the UK R&D budget goes towards this area. So it's kind of ripe for the change, and it's a really exciting space to be in because there will be changes. And policy and getting governments across the world to work together is happening, but it needs to happen in a bit more of a joined-up fashion. So that was my quick ride through pregnancy drug development, which I hope has added some colour to the pages when you explore this topic. And I'd really love to get your thoughts. Those are my email addresses. Please don't hesitate to get in touch. The more people that are on this ride, the better, really. Thank you.
Brilliant. Thank you so much, Allyah, for that great overview of sort of the historical perspective, where we are now, but also the developments for the future. And if I could just ask, what are the next steps with the Commission? Because that feels like an important piece of work.
Yeah, so I think in my last slide, I showed that there are lots of elements happening, but I think we need to have a steering committee to lead that in a joined-up way. So, things aren't lost in translation, and it's not lost from government view. We have that with the Women's Health Strategy, and key people like Leslie, June Rain, Lucy Chappell, they're all behind this. But we do need to have, I think, some people pushing this forward. So that's probably the next step, is kind of to do that.
Brilliant. Thank you.
Thank you.
Please come and join.
Thank you, Alia. And I'd now like to welcome Dr. Louise Newson to the stage for her talk on equitable access to menopause care. Louise is a GP, a leading UK menopause specialist and founder and clinical director of the largest menopause clinic in the world, Newson Health Limited. Louise is also an advisor to the NHS, is on the clinical steering committee for NHS England's Menopause Improvement Programme, and is a member of the government's newly formed Menopause Task Force. Louise has also established a not-for-profit company, Newson Health Research and Education, and she is involved in research. She's a founder and trustee of the Menopause Charity, which works to improve women and healthcare professionals' understanding of the menopause. Thanks for joining us, Louise.
Thank you. Thanks ever so much for inviting me. It's a real thrill to be here. Last time I was here, actually, I was presenting at the Royal College of GPs conference, so but it's great to be here. So just for my declarations, just for complete transparency, I have no financial declarations in that I do no paid work with any pharmaceutical companies, nor do I endorse any products. And most days I get asked to be a face or a name behind a Boots No. 7 face cream or a new shampoo, or Primark have just brought out some underwear. I'm not endorsing any of that, and nor do I work with any of these companies. My only real declaration, in fact, is that I take HRT. And if I wasn't taking it, I wouldn't be standing here, and I wouldn't have a job. I probably wouldn't have a husband at home, or 3 children that wanted to live with me either. I found it really difficult working when I was perimenopausal, but I really struggled as a white, middle-class, educated woman who was a menopause specialist to get HRT from my GP because I was refused. So I know how hard it is to get it. So I just wanted to start with a patient, actually, because it's really important, isn't it, to think about what we're doing. You know, the thing that gets me out of bed every morning is thinking about how to improve the health of women. So this is a lady. She didn't look like this. She wasn't called Marjorie, but she saw her local pharmacist. She was a 52-year-old lady and just was feeling rather so low and sad. She couldn't sleep very well, had really very tired, no energy. She just wanted a tonic to sort of lift her up and help her. It wasn't bad enough to go and see a doctor, so she just thought she'd pop into the local pharmacy. So the pharmacist said, well, I think you maybe need to see your GP. So she went along to see her GP, and she's previously very fit and well. She was struggling because she was caring for her mother who has dementia, and she'd given up work because she was finding balancing her life difficult. She was finding it very difficult to multitask and remember things, and she just wasn't performing as well as she thought she should. So she gave up her work. She had very low self-esteem, reduced self-confidence, and she admitted to her GP that she seldom went out to see her friends anymore. She had this crippling anxiety, first certainly in the early hours of the morning, overwhelming, worrying about everything, sensationalizing things. She was feeling just generally flat, just joyless. There's no zest in her life. And occasionally, her thoughts actually led her to thinking about harming herself. She knew she wouldn't do it. She didn't want to leave her family, but she was quite worried about these thoughts, which she'd never had before. So the GP thought, well, maybe you've got clinical depression. Lots of symptoms of clinical depression, so gave her some sertraline. It didn't help, actually. So then she tried some venlafaxine. It didn't help. So then she was referred to the local psychiatrist, who decided maybe she's got some bipolar and gave her some lithium. That didn't help, and she was really struggling. But she thought she wasn't depressed, but she didn't know what else she could do. So then she was given some Quetiapine. I wish I was saying I was making this up, but it's not, and I see a lot of women like this. Then she was very distraught, so she went to a private clinic that one of her friends told her about, and she was given some ketamine. I kid you not, there are a lot of ketamine clinics opening up, which apparently works very well for resistant depression. So she tried ketamine, and still she had these feelings and didn't really improve. So she decided to take control of herself, and she downloaded, we've got this free app called Balance. So she downloaded it and read some information herself and thought, I'm 52. Maybe there's something else going on. Maybe it's related to my hormones. And so she decided to complete the health report, which is just looking at symptoms. So she tracked her symptoms, printed it off, and went to another GP. And said, I think, actually, I'm menopausal, and I'm wondering how many of my symptoms are related to my menopause. So the GP quite rightly decided to ask some more questions, looking at the symptoms as well. And her last period was 2 years ago, so therefore she is menopausal. He asked about some vasomotor symptoms, and yes, she was getting a lot, but she just thought that was part of being older, so she hadn't spoken to anyone about it. But quite intrusive, you know, waking up, changing the bed, really disrupting her husband, finding it it difficult. They were now in separate bedrooms. But she was also getting some other physical symptoms, some muscle and joint pains. Her migraines were getting worse. She was getting really bad tinnitus, as well as some pins and needles in her arms and legs. She stopped wearing her contact lenses because her eyes were very dry. The GP asked about libido, and it's one of the symptoms on the questionnaire, and she said, oh gosh, no, I have no libido. She said the very few times I've had sex over the last couple of years, it's been very, very painful and uncomfortable. And actually sometimes sitting down, wearing underclothes is really quite uncomfortable, but I just thought that was part of getting older. She'd had quite a few UTIs, had several courses of antibiotics as well. So now what's the diagnosis? Well, I'm hoping, seeing as I'm a menopause specialist, you all think it's menopause, which of course it is. But is it clinical depression, though? She's still got features. Or could it be both? Like, how do we find out? How do we know? What do we do with Marjorie? And I'll come back to her at the end. You know, we're very fortunate. We've got nice guidance from the menopause that came out nearly 7 years ago now. And they're very clear. They're very clear how to make a diagnosis. They're very clear about treatment. They're very clear about the safety of HRT. But a lot of people still haven't read them, and certainly a lot of people still aren't working out of them. The menopause is the only thing, I think, that's guaranteed to affect all women. There's a lot of us out there, 51% of the population. And when we become menopausal, our hormones are low forever. So that means if the average age is 51, then 30%, around a third of our lives, is as a postmenopausal woman. And we know that our estrogen and testosterone levels decline. But I'm a physician, I'm not a gynecologist, and I worry about health risks associated with these low hormones. So actually thinking of it as a hormone deficiency with health risks is something that I think is really important to have this bigger conversation about what our hormones are. It's a massive scale of the problem, and the work that I do really scares people because, 47 million menopausal women every year. There's 1.2 billion of us worldwide, but we deserve to be listened to, and we deserve to be involved in our treatment choices because our future health is paramount. So we know from some surveys that we did, a lot of women are struggling to be listened to. We hear it all the time. It's in lots of documentation that's coming out now. We found that although the majority of women we questionnaire had seen their GP, 7% had to visit their GP more than 10 times just before getting some help and advice. That's not even treatment. And if they did get treatment, nearly half of them had to wait a year or more, but more than 10% had to wait more than 5 years for treatment. That's very clearly listed in the NICE guidance. So the menopause isn't just hot flushes, it's far more than that. And in fact, a lot of women I speak to, the hot flushes they can cope with, and even the night sweats. It's the psychological symptoms that really batter women down. And these are just words that we hear every day in the clinic. And my clinic's a private clinic. None of us could get jobs in the NHS, and menopause is really underserved. We see 4,000 women a month through the clinic, and they're women from every county in the UK, and also from every socioeconomic background as well. So there's a lot of women we see who really can't afford to come, but they have nowhere else to go and they want their lives and their jobs back as well. So I worry about women suffering with symptoms, but actually I spend a lot of time worrying about their future health. Osteoporosis affects 1 in 2 women over the age of 50. 1 in 3 women will have an osteoporotic hip fracture, costing the NHS £3 billion a year. Arthritis, sarcopenia, cardiovascular disease really increases after the menopause, and we know women that have a heart attack are more likely to die and less likely to receive treatment as well. The menopause is a cardiometabolic problem, so there's an increased risk of type 2 diabetes and obesity. We know there's an increased risk of dementia as well, especially women who have an early menopause, 1 in 100 under the age of 40, and clinical depression as well. So we did a survey of over 1,000 women, just seeing the impact on the NHS. We know it's a massive impact on in the workplace in general. Around 10% of women give up their jobs because of anxiety, fatigue, memory problems. But this is really sad. The top right figure, 37% considered reducing their hours but weren't financially able to. And 48% had considered giving up their jobs. Now, 40% of NHS employees are menopausal women. So 48% of 40% is a lot. So some of you might have seen this. This was produced by the Fawcett Society, looking at menopause and the workplace. The results are very staggering, actually, and they echo what we've done in other surveys and what other people have done as well. A lot of people don't go to their GPs because they think it's a natural process. Why on earth would you go and pester a GP? They wouldn't want HRT because a lot of them are scared of the cancer risk, and around a quarter just feel they don't know enough, they don't know who to get information from. And women are really being neglected. From this survey, it found that nearly a third of women had had many appointments before a diagnosis had been made, but this number increased if they were women of colour or they were women with more than 5 symptoms. We see a lot of women in our clinic who are misdiagnosed with fibromyalgia, chronic fatigue. A lot of them have been given antidepressants, and even long COVID, actually. A lot of women now are menopausal or perimenopausal and long COVID, and no one's thinking about their hormones. So there are lots of treatments available, and it's really important, the NICE guidance tell us, and of course it is, that we have individualized treatment. Information is key, and I spend a lot of time batting out information. So on our website, we've got over 2,500 resources. There's booklets, I do a weekly podcast, there's videos, there's fact sheets, lots of information on the app. We're doing translations as well into lots of other languages. So it's really important that women get the information that they want, which is based on the best available evidence. We're doing a lot of awareness in corporates and companies and other places as well. So it's not just about hot flushes. We can be thinking about other symptoms as well. And for me, anything I do in medicine is about respecting patient choice. We're all individuals, and our choice might change at different times, but we need to be allowed to explore any potential risks as well as any potential benefits of treatment. And certainly, I love my clinical job because it's transformational medicine. I not only can improve symptoms, but I can improve future health and actually allow women to not go and drain the NHS. But there's a lot of pushback, isn't there? HRT is a lifestyle drug. We're all shown these celebrities and we're saying, well, look at their lovely skin and hair. We could look like that if we take HRT. But actually, we have to remember more what HRT is doing. But HRT is very scary for a lot of women. The media are constantly telling us how it increases our risk of cancer, increases our risk of heart disease. We've now got the Davina Effect, where a lot of people are thinking, well, women just want to look like Davina, and that's why they're taking HRT. And Davina has done an amazing work about awareness, but we need to follow that on and think about why are women wanting their own hormones back. A lot of women are medicalized for the menopause already. The majority of women we see and speak to have already been given antidepressants. And this just shows, after the WHI study that came out 20 years ago, that since HRT prescribing reduced, the incidence and prevalence of antidepressant prescribing has increased. No surprise, really. So HRT is only 3 letters. There are different types, there are different doses. It's not a one-size-fits-all. We spend a lot of time optimizing people's hormones so they have the right level of estrogen, progesterone if they need it, but also testosterone is another important hormone. So women are allowed a choice as well. There's a massive postcode lottery of prescribing for HRT. The cold areas, the blue areas, are really low prescribing rates. And in some areas, it's as low as 2% of women who are menopausal who receive HRT. No surprise, the southeast, more effluent, much more estrogen is prescribed there. So what are the benefits? Well, women feel better because you're replacing the missing hormones, so that's lovely, isn't it? But actually, we know that the benefits outweigh any risks. It reduces the risk of all these conditions, which is really important because most women die from heart disease and dementia, as you know. This is a really good paper that recently came out in Climacteric, saying that menopausal hormonal therapy, why we should no longer be afraid of the breast cancer risk, and it unpicks the evidence in a very eloquent, unbiased way. And it says preventing a woman from the sound benefits of a properly instituted hormonal medication, which is what HRT is, just for the fear of rare side effects is not satisfactory medicine. And I challenge anyone to oppose that view. But if we try and find out more information, you go to the NHS Net and you put in menopause and it will talk about how you can raise your increased risk of breast cancer. Then you go to the BNF to try and prescribe it and it will say the risk of ovarian cancer, risk of endometrial cancer, of breast cancer. It's very, very scary, isn't it? And then this letter was written in 2019 by the MHRA to all women and also people who prescribe to say risk of breast cancer, lowest dose, shortest length of time. There's no evidence to support this. This was based on a Lancet meta-analysis in 2019, which was based on the unpublished data, as well as the Million Women study, which has been discredited. All about risk, nothing here about benefits at all. And even if I want to prescribe Vagifem, which has no systemic absorption, is absolutely fine for women who've had breast cancer, it will tell me there's a risk of clot. How can something in my vagina get in and increase my risk of clot or breast cancer? And this is what is putting people off prescribing. If you look at primary prevention, I've just compared this with statins, and you'll see the risk reduction of coronary heart disease with HRT when started within 10 years of the menopause is lower than with a statin, and also all-cause mortality is lower. Yet women are pushed to taking statins for primary prevention of cardiovascular disease and not HRT. This is just a survey that was linked with a faucet to show that a lot of women are, there's only 14% taking HRT, and those that did actually have really improved, but they're still scared about it. They're worried about side effects. A lot of women, about a third of women who come to our clinic are on HRT, but they're not on the right dose or type. Now, a lot of the work that we've been doing and others have been doing has actually led to shortages, which is a real problem, actually, once women start to feel better. And that's because of increased demand, but it's only gone up from 10% to 14%. And I've already said in some areas it's a lot lower. So what happens when more women get it? It's an absolute nightmare and travesty for women. If I wasn't taking HRT, it would just be awful. So there's a discussion, we need an Nhs National Formulary. It depends on where you live. Because of this postcode lottery, there's Bijuve, which is a body-identical combination tablet. It's only available in 11 ccGs, so the majority of GPs can't prescribe it. So I was on this morning last week talking about how important it would be to have a national formulary. And then we've got testosterone, important hormone for many women. We're allowed to prescribe it according to NICE if women have got reduced sexual desire. But a lot of people have refused it. There's a lot of lack of training, a lot of GPs refuse, and other healthcare professionals. They're not listening and reading the NICE guidance, but also a lot of time they're not allowed. A lot of CCGs say it has to be initiated in a specialist menopause clinic, there's very few of those, by a gynecologist. And I have nothing against gynecologists, but actually GPs who are trained know as much, or if not more, than some gynecologists. And then we've got this whole HRT over-the-counter, but this isn't HRT. This is Vagifem that's available to some women who are over the age of 50, can buy it over-the-counter. But actually, HRT, systemic HRT, is safer than Viagra. So why can't we buy it over-the-counter? We can buy it over-the-counter in Spain, but not in the UK. And actually, it is very safe. There are very few contraindications. So just towards the end, going back to Marjorie, she was given some estrogen through the skin, no risk of clot or stroke. She was given it, and she also was given some progesterone as well. 6 months later, she still had reduced libido. She felt very tired and flat still. So she was given some testosterone. Obviously, in the NHS, you have to prescribe male testosterone because men are allowed testosterone in lower doses to women. And then on her 9-month review, she was feeling back to normal. She was feeling like herself. She applied for another job. All her symptoms had gone. She was really looking forward to the future, which she hadn't been before. Very important, the difference that it made to her. So it's a very quick talk, but I hope really, once you start thinking about the menopause, you can't unsee it really, and I wish I could go back in time and treat the many women I've seen in casualty, in hospital, in GP practices and home visits, and just didn't even think about the menopause. And this is just a free education program for any healthcare professional where we've got videos and lectures where you can link to the evidence and hopefully upskill so you can do your female patients a service. So thank you very much.
Thank you so much, Louise. Setting out the scale of the problem, but also bringing it down to the individual patient and the kind of impact on quality of life. Personally, I find it heartbreaking, and I think we really need to do better. And it really struck me, one, the point that you made about the importance of integrated care, rather than picking things up separately and not seeing the menopause. But the other thing that seems really important is that the evidence base that's out there, and you're talking about the work you're doing to improve communication and actually people acting on the evidence that's out there. So I think I'd like to ask, what are your priorities for kind of making that happen? And then secondly, are there any areas, we've got a room full of pharmacologists and clinical pharmacologists here, are there any areas where you think we need to build on that evidence base and more research, we need more research?
Yeah, absolutely. I mean, we're doing a lot of work looking at social deprivation and inequality, and because we know these women are really neglected, we're doing a lot of work in prisons, for example, as well, because they can't access a phone, they can't access balance. So I think it's about a joined-up approach. It's not thinking about it as a women's health problem. It's not a gynecological problem. It's a systemic problem with disease risks. I'm also very interested in polypharmacy as well. So a lot of women we see can come off their medications. So this lady, for example, came off her heavy-duty medication. But also looking at what we're doing with some of the other medications. Quetiapine, as you know, will increase prolactin, which will suppress FSH, which will also suppress estradiol and testosterone. So we're giving people chemical menopauses without thinking about it. So it's looking about what we're prescribing instead of HRT and why we're not prescribing HRT. So increasing some research in these areas, I think, is really important.
Thank you.
Thank you. So I'm delighted to welcome Dr. Sarah Mead to the stage to talk about regulatory challenges. Sarah is the medical lead for MHRA on a number of high-profile important patient safety issues relating to the safety of medicines and vaccines used during pregnancy, including sodium valproate, isotretinoin, the SSRIs, and COVID-19 vaccines. And Sarah's worked on the development and implementation of several regulatory guidelines relating to medicines use in pregnancy, including the Valproate Pregnancy Prevention Programme. And Sarah has a clinical background in psychiatry with speciality in perinatal work in the UK and Australia, and a postgrad qualification and experience in reproductive toxicity, and has also spent 7 years as a medical advisor and pharmacovigilance head at a large pharma company in Australia, and been with the MHRA for 14 years. So thank you, Sarah.
Thank you very much, Sheuli. I'm here today to talk to you about the MHRA regulatory priorities for women's health. And my first slide, which should upload at any moment. There's a lot to get through in 15 minutes, but I will talk as quickly as I can. We'll wait for the slides to upload. Thank you. So if I go right back to where the current gaps in drug development are, I'm sure everyone in the room is more than aware that all of the phase 1 studies are typically in human healthy volunteers, and this cohort is usually men aged 18 to 35. Now, the PK and PD differences between the sexes are significant, and we recognise there's an urgent need to improve the diversity in recruitment to trials at all stages of drug development. We often are in a situation at the time of licensing where the pathology in each trimester of pregnancy is largely ill-defined, and this leads to clinical difficulties as pregnancy progresses in women, particularly those with chronic diseases who need to maximise their maternal health whilst minimising any potential harm to their fetus. Pregnant women and breastfeeding women have been historically excluded from clinical trials, and the clinical significance of all of the preclinical studies that we have when the dossier comes to us for licensing assessment is bridged by post-marketing data. And that's a situation that hasn't really changed within the 14 years that I've specialised at the MHRA in regulation of vaccines and medicines in pregnancy. The specific age-dependent women's health conditions, the feedback that we've got is they're seen as low priority, and certainly post-pandemic, the gynecology waiting lists and access to treatments have never been in more dire need to be prioritised. And I think certainly working providing scientific advice for companies, then if we're to look at the number of scientific advice or applications for innovative licensing, then the R&D in women's health are certainly one of the lesser considered areas for research. There are changing health needs across the life cycle, so during the fertile period, the reproductive function of a female seems to take a lot of the patient and the healthcare professional's time. whether that is cyclical change and the morbidity associated with the menstrual cycle and conditions such as premenstrual dysphoric disorder, which are historically quite poorly managed, or whether that's help with the menstrual cycle through the use of contraceptive pills. More recently, young women have been encouraged to take up the HPV vaccine with important cervical cancer risk reduction properties, and the gynecological conditions such as endometriosis, menorrhagia, these sorts of conditions with polycystic ovary, they are something that takes up a lot of the woman's time, a lot of the healthcare professionals' time trying to manage and not to just be accepted as part and parcel of being female. When we look at the conversations that women have to have with their doctors around pregnancy planning, around risks, teratogenic risks of the medication that they might be taking, the difficult conversations around pregnancy loss, conversations around fertility, and then we get to the perimenopausal period. It's no surprise that women present to the doctor more frequently than men. These are influences on the reproductive function of women that really take precedence over those background general health concerns that affect all people. The perimenopause is an area which has been increasingly recognized as something that is very important to manage well, and again, not to be accepted as part and parcel of a woman aging. In 2018, the then Secretary of State for Health, Jeremy Hunt, commissioned a report that's widely known as the Cumberledge Report, and it looked into 3 areas of government response to vaginal mesh, to Primodos, and to sodium valproate. And the overwhelming response from the people who took part in compiling the Cumberledge Report was that women felt they weren't heard. They were struggling to have conversations with healthcare professionals. They weren't believed about the symptoms they were experiencing, and they felt abandoned by their prescribers and the wider healthcare system. In the vision for the Women's Health Strategy for England, led by the Department of Health and Social Care, then 2/3 of those 100,000 respondents said that their current health condition wasn't adequately supported by their healthcare professional. Overall, services for women are considered to be a much lower priority than other areas of healthcare, and a situation that we're keen to work together to change. At MHRA, we've always been about putting patients first, and the patient engagement department has worked very hard to ensure that patients' views are adequately represented when we're considering very complex regulatory change. Most recently, patients have attended meetings of our Commission on Human Medicines and been really vital in guiding regulatory decision-making. I'd like to talk a little bit about my specialist area, which is the challenges of pregnancy. And it could be considered as either a 2 or a 3-compartment PD model, depending on whether or not the uteroplacental circulation is included here. And as my colleague Allyah was explaining, the average age of women having a first pregnancy is increasing, and therefore the number of medications that women take during pregnancy is also increasing. Unlike women who aren't pregnant, women have chronic diseases which need to be controlled. I spoke about maximizing maternal disease control, minimizing fetal harms. Certainly in the area that I've worked a lot in, epilepsy, it's a challenging group of drugs to find stratified risk of harms to fetus and adequate disease control in mother. There are also illnesses that will occur during pregnancy, as a consequence of pregnancy, or coincident to pregnancy, and all of these conditions require management as in the non-pregnant state where possible. The advice at the moment for people planning a pregnancy or people already pregnant is inconsistent and something that we're working hard to change. The current drug regulatory system is based upon a dossier which would include non-clinical data when the license application is received. And the malformative effects that are seen in the early phase animal studies, the clinical significance of these is very difficult to interpret because species-specific effects are known to occur. So we end up with a lack of information, really, at the time of license for many products, and women go to various different sources for their information. The SPC and inconsistencies based on the volume of post-marketing clinical data often lead to very difficult decisions around staying on medication versus switching to alternatives or stopping medication completely. So we are really keen to ensure better consistency of information for women and their prescribers. The over-reliance on non-clinical data historically has been something that we're very keen to improve, given sodium valproate has been shown for many, many years, since the early 70s, to have an effect on the neural tube development, and the valproate-specific neural tube defects don't seem to be sensitive to folic acid. Within the routine battery of non-clinical studies, we were aware of neural tube defects. Where the data were lacking were the effects on neurodevelopmental disorders in those children who were exposed. So I've talked about the translatability. How well can we extrapolate non-clinical data to the clinical world? I think it's very challenging, but I'm pleased to say things are improving in that area. We have a new challenge within reproductive toxicity assessment relating to epigenetic effects. This area of research of the epigenome effects in germ cells is something that is going to be applied more to drug development assessments, and something that might be responsible for transgenerational effects of certain medicines. The need for information never been more important with the internet, and this study showing from the Teratology Information Services that women consult the internet almost as commonly as they do their doctor for information about the safety of their medicines when taken in pregnancy. It's never been more important then that we get it right, that they feel they've got somewhere authoritative, up-to-date information to go to and trusted sources when making really difficult decisions about their own health and their health of their child. Just to put onto one slide some of the resources and collaborations that we at MHRA are engaged with to try to improve the situation around regulation of products used in women's health. We have in the post-Brexit space a joint meeting with the FDA and EMA on a regular basis. We call it our pregnancy cluster meetings, and we discuss all safety issues that are happening within our local territories. We've also been active. Alia discussed the ICH guidance on including women in clinical trials, pregnant women for clinical trials. We were able to work together on presentations to raise the profile and importance through the Mhra organisation on why this should be considered for new ICH guidance this year. The Safer Medicines in Pregnancy and Breastfeeding Consortium has been set up and involves a number of healthcare system partners. The mailbox is a resource for everyone working in healthcare to let us know about inconsistencies in product information out there. So we meet regularly through the consortium, and we try to work together to achieve the best possible data sources to inform the best possible information for women, and to host consistent advice on the various different platforms available to us all. The Conception Project, there's a work package within there, and we are working towards developing something where we could hopefully pick up neurological differences in children exposed to different drugs during pregnancy to better early stratify the risk across a therapeutic area. I'm particularly thinking about valproate, but people may have read the recent study from in the JAMA report around topiramate. So neurodevelopmental harms, really difficult data to adequately compile, but hopefully within the work of the My Conception, routinely collected data like in the Ages and Stages questionnaire can be more systemically and systematically assessed and lead to earlier labelling and advice for pregnant women and healthcare professionals. MHRA has secured funding through the Gates Foundation for PK/PD studies and for placental transfer, milk transfer studies. The MHRA have run a workshop for healthcare professionals to discuss the importance of PK during the different stages of pregnancy. The CHM convened an expert working group on optimizing data on medicines for use in pregnancy and published a report bringing together the various data sources and how best to use them when making decisions and informing policy and regulatory guidance. Within the innovative licensing and application procedure, there is an early consideration of underserved populations, such as pregnant patients. And within our scientific advice, more and more patients are around the table with us. I'll discuss the CPRD pregnancy register a little more in a further slide. The Yellow Card Biobank is an interesting project that we will hopefully be able to take forward some study into looking at teratogen risk factors and why a drug is teratogenic in some fetal exposures and not in others. And the patient and public engagement side to work at MHRA is evolving, and the valproate stakeholder network is something that I've been very heavily involved with, and task and finish groups are more commonplace to make sure the implementation is guided by patients. I haven't got time here, but I could talk about the NHS Medicines in Pregnancy Registry, which MHRA set up with NHS Digital, really guiding the impact of our regulatory measures and helping us to monitor for unintended consequences, switching practices, and making sure that women are switched to alternatives without undue harm. This slide represents some of the membership of our valproate stakeholder network. This was convened when the pregnancy prevention program for valproate was brought in, and the implementation has been guided through the patient groups and through other members on the slide here. I touched on the CPRD pregnancy register. In 2017, there was an algorithm created that allowed us to link pregnancies with outcomes through the CPRD database, and that's been used for the data source for a number of publications. The UK prevalence study looking at the prevalence of underlying conditions that increase the risk of severe COVID was one of the most recent publications, and illustrates how the CPRD can be used in this way, but it's one of many examples. In discussing the COVID pandemic, we're committed to reducing bias in development of new products. It was a difficult situation to see that pregnant women were often denied access to potentially life-saving drugs in a life-threatening situation during the pandemic. And when we looked at the trials that have been submitted to us, there was only 1.7% that specifically included pregnant women, of which just 3 were interventional. We're involved in ongoing consultations with the aim of trying to reduce some of these biases, and there's responses under review for one consultation on improving inclusion of underserved populations, including pregnant women in clinical trials, and hopefully the ICH efficacy guidance that will be starting to be drafted at some point this year will further help to establish some ground rules for industry and help to de-risk some of these areas of drug development that historically have been in play. There's a consultation on medical devices as well, and we will expect new guidance to be drafted here. So in summary, the women's health needs change significantly across the life cycle. The continued safety concerns highlight a need for an increased focus on women's health, and I think information needs to reflect benefits as well as risks more fully for informed decision-making on behalf of the patient and healthcare professional. As regulators, we're committed to reducing bias in the development of new medicines and to support the development of new treatments for all gynecological conditions, and particularly in the post-menopausal health space and for use during pregnancy. Committed to improving the information available for medicines and vaccines during pregnancy and breastfeeding. But we can't do this alone. The implementation of any regulatory initiatives requires a system-wide, joined-up collaborative approach. And working in partnership with everyone in this room is going to be very important for success. Thank you.
Thank you so much, Sarah, for that overview of the life course view and the regulatory perspective. Could I just ask you, you mentioned about that balance between information on benefits and risks. How can we get that balance right?
I think we would look to wider clinical guidance as regulators to present the benefit as historically focused on risks is something that individual product information, according to the SPC guidance, doesn't have underpinning the framework for it. So the indication section of the SPC would give the license indication for which the studies were submitted, on which a benefit risk is represented. And feedback is that we represent risk very well, but we don't have the benefit there. And I think that's where in the post-Brexit space, as regulators, we can probably publish more in terms of patient safety leaflets and help with clinical guidance where the benefit risk can be balanced in a way that is interpretable to the patient and healthcare professional. I think within the EU guidance and the formal SPC guidance, it's been more difficult to do, but there's a lot of appetite in the agency to have these balanced discussions underpinned by balanced documents. And I think the patient safety leaflet for the anti-epileptic group was one of the first leaflets we were able to do that spans a whole therapeutic area. Normally we tick off one drug license at a time, which doesn't give us an adequate reflection of the risk stratification within a therapeutic area, or indeed benefits, comparative benefits.
Brilliant.
Thank you.
Thank you. Please come over and we'll move to the panel discussion now. So we're going to invite all our speakers to be part of the panel discussion. So for those of you sitting here, please be ready to give us your questions in a few minutes. We'd love to hear from you. And those who are joining us online, please use the app to submit questions and they'll come into the room. So maybe to open the discussion, it'd be great to hear sort of briefly from each of you what led you to be interested in women's health. Alia, would you like to kick off?
Yeah, I mean, I'm very much interested in improving health for underserved populations, going beyond, our classic stereotype in phase 1 studies, which is, a white 18 to 35-year-old gentleman, and making sure we have the drugs correct, which I saw a lot of as a cardiology doctor for many years, but making sure that we develop drugs for, ethnicities, and gender, and the fact that women make up 51% of the population, but we're still struggling in these huge areas, I think made it quite clear that this was an area that needed some work, and I'm very, very grateful to be part of it, to be honest.
Louise, what's...
Yeah, I think I actually don't see myself as a women's health specialist because I think every person that I see either is associated with a man or knows a man or works with a man, and it's not about gender here, this is about health actually, because actually if women's health is suffering, then men's health are usually suffering as well, either because they're not getting their washing done, they're not getting the dishwasher unloaded, or they're not being able to have the same conversations with their work colleagues. So I'm very interested in preventing disease, and I think the menopause is something that, there's estrogen receptors on every single cell in our body, so it's the only real multidisciplinary sort of specialty that I think that embraces everything. So I love the fact that it's using my, I've got a pathology degree as well, so I've got a bit of a geeky brain. It's also using my hospital medicine. It's using my general practice skills as well, but there's a lot of mental health. So it's touching on every single area, and that's a great privilege, isn't it, to really look after the whole person.
And Sarah?
Thank you. I think it was my mother and baby unit work as a trainee and then as a perinatal psychiatrist in Australia, and witnessing the vulnerability of the female in the postnatal period and the impact on the child, and the mutism in a particularly profoundly depressed lady, her young son, who was given speech and language therapy and had absolutely nothing neurologically preventing him from talking, but a mute mum with the profound depression and the effects that can have in the postnatal period. And I felt a great sense of advocacy for women at that time in their life. As my colleague Louise said, it doesn't just affect the woman, it affects the baby, it affects the entire family. And I was quite horrified when I came into drug regulation and realised that nothing much was happening about 20 years ago, and just couldn't accept the status quo, and just want to work very hard at making medicines available as soon as possible to women. During the pandemic, again, it was highlighted, heartbreaking stories of women being denied access, or through poor information, having vaccine hesitancy, and then too late to regret their choice often, and it's something that we can't accept.
Yeah.
Thank you.
Yeah, thank you. We heard a lot in your presentations and just now about this being a general health and a global health challenge, and yet we also heard that women's health has been historically low priority, still struggling to raise up that priority, although we'll come on to whether that might be changing. So, and what extent do you think this idea that women's health is a women's issue, to what extent do you think that is still live and kind of influencing in terms of what we prioritise as a society, what we value and how, and to what extent do you think that we're really starting to see that shifting kind of through your professional, also personal experiences? Feel free to jump in or go through the same order.
I'm happy to say, I think there's a lot of talk, which is great, which there wasn't before. You know, when I was very young, my father had a brain tumour and died from cancer, and you couldn't talk about cancer in the 70s. And when I was qualifying in the 90s, you didn't talk about mental health, you didn't talk about depression. And like menopause is something that you've just not been allowed to talk about. And then if you do, it's almost a bit of a joke, isn't it? You Google menopause and it's always a white, elderly woman with grey hair with a fan. And it's like, actually, most of us don't look like that, and we don't need to look like that. So I feel like the conversation is starting, which is great, but actually talking about it is just not enough. And I think it's almost gone the other way, that we're a bit tired of listening about the menopause. And it's like, oh, will you just shut up about your hormones? And actually, it's not just about menopause, perimenopause, postnatal depression, PMDD, PMS. This is all hormonal imbalances. So we need to think about regulating hormones and giving them as soon as there is a hormonal deficiency. So, you know, postnatal depression, why aren't we giving estrogen to these women? Because we know there's a massive decline. So we don't need to be labelled, and we're doing some research actually about the mislabeling of women and the ethics behind it. Because, you know, we don't need to be labelled, we just need a solution, and we need to be taken seriously, but we also need to move forwards to improve our health. So we don't need all these obstacles getting in our way. And I think it's really encouraging hearing just thinking about benefits, like we've just told no the whole time, and that's got to change. And I know men struggle, you know, look at testosterone deficiency in men, that's a real problem. So I don't want it to be too much of a gender thing, because then we lose picture of everything that we're trying to do, I think.
Thank you.
I mean, for me, recently at the European Society of Cardiology, which was on the summer bank holiday, why it's always at a weekend is just frustrating, but it was, and it is. One of the key themes was women's heart health, and there are several big studies that have just come out. But one of the issues that, you know, I've always struggled with is the fact that, you know, as my colleagues have mentioned, is that it has that label and it's not holistic health. You know, we can clearly envisage what a man having a heart attack looks like. You know, he's going to be like, you know, paying down his left arm. You know, women's symptoms are more subtle, but we don't recognize that we delay diagnosis. We miss the time where we should be doing a PCI because we haven't actually gone back and made sure that research all the way from, you know, those lab mice has included thoughts for the female physiology, for female bespoke PK and PD. We've missed all of that. So, you know, for me, it's now a really exciting time to kind of pull along and move forward to get that work done. And it is happening, which is and even in very challenging areas like pregnancy, drug development, it is happening. So a lot of positive signs, and I think we're going to see a lot of change in the next decade.
So maybe if I can come in then and maybe bring Sarah in on the next. So when it comes to hearing those women's voices, how do we balance, you know, what's the balance between enabling women to speak, but also giving responsibility to researchers and healthcare? I mean, you talked about both in your presentation, so how do we get both sides moving, as it were?
I think it's really challenging because I think particularly drug regulation, it's one of those areas that evolves, and I think having an easy read or a lay version of regulatory guidance, medicines legislation is quite challenging to explain all the steps that a drug has to go through. So whilst the patient voice may give us the output and the feedback, it's almost the way the process is set up now, it's too late. That's why we need people early in the process of drug development to say, actually, what is this going to mean for you at the end? So I think the balance between taking all of the feedback from women around what they need is as far back as early scientific advice with companies, making sure that that voice is represented, so that whatever we put into play, we're taking underserved populations considerations into play right at the very early stages of scientific advice.
Louise or Alia, do you want to come in? Okay.
I was actually wondering whether I could chuck in. I'm interested in the role of education and where you think that stands right now, how well represented this is in medical and scientific training, and kind of maybe I'm speaking with my BPS hat on now because obviously that's a focus for us. And kind of how do you see that sitting right now, and where do you think the priorities are?
Well, especially in the menopause, I can't think of any healthcare professional that shouldn't know about the menopause. You could say maybe paediatricians, but then my youngest patient's 14 who was menopausal. So, and I know that as an undergraduate and a postgraduate, I had no formal training in the menopause, so it's all been very self-directed. So our education program has been downloaded by 26,000 healthcare professionals in the last year. And that just shows that there is a demand, you know, people want to learn, but it's been very difficult to access the right information. So I think it is really important that we can allow education to improve, but in parallel with research, you know, menopause research, we know that women's health research is bad, but menopause research, there's just nothing. In the last 20 years, it's very, very scanty, and it's not moving forward, which is a great shame.
I would say education needs to be a bit more creative and up to date. Having things in undergraduate curriculums is great, but people are changing. We're now, you know, in the era of startups, biotechs, everything is online. So for me, as someone who's involved in biotech, I'm very keen that understanding and education of the drug development process with, you know, elements for women should be available on learning platforms for free online, but they're not. You know, it is, as Sarah said, a really confused, you know, difficult to gauge area where you need to get experts and consultants and everything, but it really doesn't have to be that way. And, you know, we have excellent, creative, independent regulators now in the form of the MHRA, who are reaching out to drug developers, academic spin-offs, and they want to have that conversation. So for me, allowing people to understand that that's present and educating them in that way, I think would be a dynamic way to move forward.
Thank you. Did you want to come in, Sarah?
I think it's the source of the educational content as well that's particularly challenging for women themselves. Where do they go to get that information? The Pregnancy Consortium, all of the groups, they all feel that they have the best possible source of information on their sites and often come to us as regulators for endorsement of information, and that's really difficult, particularly in this area where it's evolving all the time. We think we know the teratogenic risk of medication, and then there's a publication the day after we've communicated showing, something different. So I think having authoritative, up-to-date information is a real challenge, and I think just partnership, really, between patient groups and regulators, academic bodies, royal colleges. That's why these consortia are so important, is trying to get one source of information for people. I think it's challenge we might never meet. It does seem like a dream at the moment, and to keep it constantly updated. But I think the education for women and being able to signpost them to somewhere that is going to give them the best information for them is really challenging, because obviously regulation is population health. Individual benefits and risks are those decisions that the prescribers sitting facing every day that are out with the remit of the regulatory license for a product, but certainly something for educational clinical guidance and symposia, and we need patients at the table for that.
Definitely. And actually that's something that BPS assessment is working at the moment in terms of with MHRA in terms of prescribing guidance and during pregnancy and also menopause. So hopefully there's stuff that we can start to keep taking away and moving along. But I guess maybe I've been feeling quite hopeful that some of these, it feels like we're talking about these things at a national level at a symposium like this, and it feels like it is at the top of, well, maybe not the top, but it is kind of coming above the waterline in terms of a national conversation at least. And I think I'm really interested to know how hopeful, you're much closer to it than I am, how hopeful do you feel that initiatives like the Women's Health Strategy, like all the things we've been talking for England, I should say, and obviously Scotland has a Women's Health Plan as well, these sorts of initiatives, the things we've been talking about today, do you think we are getting to that tipping point, that step change? And what do you think will be the one thing that kind of could push us over the edge in a positive way?
Silence. I think, I don't know, I sometimes think we take 2 steps forward and 1 step back, actually. That's a problem. And I think everyone's, I don't know, I'd like to say yes, but I do think there's a lot of fear because it's such a big problem when I'm talking about the menopause, but I think just women in general. So I think it's easier to ignore it, pretend it's not going away, or pretend it is going to go away, and it clearly won't. Women aren't going to. I also feel a bit guilty of some of my work, actually, because I've done a lot to increase awareness for women and those around them, so in workplaces and so forth. So now women are realizing that they don't have to take antidepressants, they don't have to be sectioned, they don't have to take other medications such as, for their blood pressure or for their muscle and joint pain or their migraines, but then they can't get the treatment that they want. And so, I actually find the non-clinical part of my work really harrowing, actually, and really distressing, the stories that we hear. And it's not just me that's hearing them. You just read the strategy document, they're all there, and I feel a bit guilty almost because these women they've got this big carrot dangling above them, but they can't access it. Yeah. And when you reach areas of deprivation, they're far more likely to have mental health issues, be overweight, have diabetes, yet they can't get the right treatment that's available for them. So
it really is important that we come together on these.
Absolutely, totally.
Sarah, did you want to come in?
Yeah, I mean, in the regulatory space, and I can speak today as a regulator, I think post-Brexit we have a number of opportunities now where we can work on a national level and implement regulatory change that is consistent with our own healthcare system. And I think that we can be more creative than before in actually going from paper to practice. For example, pregnancy prevention programs on paper are very different to in practice, where patient choice comes into play and difficult benefit-risk decisions sit in front of doctors every day. So I do feel hopeful. I think if it's directly proportional to the passion and the commitment, enthusiasm of everyone working in women's health, we should be making really, really big leaps. So overall hopeful.
Allyah?
Yeah, I definitely feel that there is an air of positivity. Things like the women's health strategy are helpful because they allow, women to, place their view squarely on the table. There was more than 100,000 people who contributed into the women's health strategy, and usually when government does this kind of thing, you get, hundreds, maybe a couple of thousand of responses. It's a challenge, though, because there is, as everyone's saying, so much ground to cover. This whole topic of women's health, probably pediatric health and ethnic groups as well, have been left behind for so long that, how do you tackle it all? And I think that's one of the criticisms of the women's health strategy is there wasn't enough bang for your buck. In terms of actual investment, there was, 10 mil kind of signposted for screening in terms of breast cancer and those kind of things. These are pitiful amounts. So actually, the government putting their hand in their pocket and bringing out, real funding, I think is imperative. But I think with people like Leslie Reagan, who is a force, at the helm, she will be asking for accountability and, and I see that across many academic institutes. At Imperial, we've got the George Institute, and people are now demanding to see, for example, in a clinical trial, why is there not data, for women in terms of a drug that is going to be prescribed for women in the future? So, yes, there's positivities. There's a lot more that needs to be done, but we have to make baby steps first, right?
Okay, the door's opening, but we need to push.
Yeah.
Brilliant. So just before we go to the audience, because I think we'll have time for a couple of questions, for each of you, if you had a magic wand, what would you change to move this forward? And please, also, where would you like to see our organisation, so BPS and the faculty, what could we do to help? So maybe, Sarah, if I come to you, then Louise, then Alia.
Yeah, very briefly, I think just to bridge that clinico-regulatory divide, as I was saying about things on paper, things on product licenses, it's about implementation. It's about that feedback loop from everyone on the ground so that the regulator isn't in an ivory tower, in an ideal case scenario, implementing regulatory change without any recognition of consequence. So for me, it's bridging the clinico-regulatory divide.
Louise?
Mine's really just allowing every woman that wants her hormones back to have them back. That's all.
Thank you. And Alia?
For me, it would be advocacy for all of these issues and better communication, so that we're not always in the tangle of risk being everything, but we understand that, improving pregnancy has, an impact on your grandchildren, so it's a population health thing if you can improve the 9 months of pregnancy. Not making these such scary things, but getting our communication to doctors, to patients, to literally everybody a little bit better, a little bit slicker.
Mm-hmm. Brilliant, brilliant. Okay, I think can we have some questions from the audience?
So you have some standing mics in the room. Please do go to them if you've got questions. We'll come to you. We've also asked people online to submit questions. I think there are a couple of the team who have been monitoring that for us. If you're one of them, could I ask you to stand by microphone stand 2 if you've got some questions, and so you could read them out to us. But I can see microphone 1 if you'd like to introduce yourself and ask a question to the panel. Thank you.
Hi, I'm Sarah Bailey at the University of Bath. I'm really just a question to Louise about menopause. You say that your aspiration is for women to get their hormones back if they want them. Are you really advocating for lifelong HRT, that women should be on it till the end of their lives, almost, from the period of menopause? Or, are they at some point going to have to come off the HRT and go through a non-hormone replaced menopause at some point? Just a
Yeah, so it's not about what I advocate, it's what the guidelines are. So the International Menopause Society, the British Menopause Society and NICE are very clear that as long as the benefits outweigh the risks, women can take HRT forever because it is a long-term hormone deficiency as well. So as soon as a woman stops HRT, she might or might not have her symptoms, but then she's got increased risk of osteoporosis, diabetes, dementia and heart disease. So the whole thing about coming off earlier is because of the risk of breast cancer. But we know that estrogen-only HRT is associated with about 22% lower risk of breast cancer. That's WHI's data. The increased risk is associated with the synthetic progestogens, which we tend not to prescribe. We use micronized progesterone. Even if you look at the worst study with the worst figures, that increased risk of breast cancer is less than a risk a woman has if she's overweight or if she drinks a couple of glasses of wine most nights or if she doesn't exercise, because those lifestyle modifications are risks for breast cancer. Any woman who takes any type of HRT has a lower risk of dying from breast cancer and also a lower risk of dying from heart disease as well. So again, it's about individualization of choice. So it's important that women understand the benefits of continuing HRT. But HRT is not the only treatment. It's important to look holistically at lifestyle as well. So there's no point me taking HRT and smoking 20 a day and eating McDonald's for breakfast. It's not going to do it. So it's really important. So we just review people every year and then we have this discussion themselves.
Thank you. I'm going to go to microphone 2 next.
Well, I think Martin was actually here
was
before
he?
me, so I'll let him go
I'll
first.
do that then.
Rita, you want to have the last word as always.
Oh, no, I'll go next then.
Okay. The key learning, Martin Michel from Mainz, Germany, the key learning I took from this session is this huge need will not be served well as long as we consider it a female problem and not a societal problem. And I think that really needs to be all in front of all communication in this regard. And while listening, actually I wasn't aware of that. You said menopause sets in at 51 by average, and a lot of people drop out of the workforce because they cannot really handle that. Well, in all industrialized countries, we are currently complaining of a lack of skilled labor. If we have a lot of women who have a lot of experience and theoretically have another 15 to 20 productive years in the workforce, and a major fraction of them drops out because we don't address their menopause problems, that's not a female problem. We are running out of workforce, and in the 21st centuries, societies that allow skilled people to drop out of the workforce will not be successful. And I'm a numbers man. That's where the money is.
You're absolutely right, because it's not just the personal cost to women who can't afford to give up their jobs, but it's also to the economy, to tax, because they're not paying national insurance or their taxes as well. It's a huge problem. I did a lot of work with the West Midlands Police, and we found that the vast majority of these women were really struggling with, concentration problems, anxiety, and energy problems as well. Yet a lot of them were signed off with anxiety, depression, migraines, didn't even realise their symptoms were due to the menopause. And when I work with a government, they talk about having menopause leave or flexible working, reducing hours. Reducing hours equals reduced pay, doesn't it? But it also, these women don't want to. We see women who've been off work for 10, 20 years. They're just at home. They're just not enjoying their lives. They want to work, but they just can't think. They can't work in the same way, or they do a physical job if they've got muscle or joint pains. So I do a lot of work with corporates, and I find it really sad that I just get bombarded with these women saying, but how do I get hormones? How do I get them? Because I'm being refused all the time. And I can't think of any other evidence-based treatment that is refused for the wrong reasons, really.
Thank you. Please.
I'm Rita Alawala, Queen Mary, University of London. I've very much enjoyed the discussion. I've sort of got a question that carries on from Sarah's question. So in WHI, they stopped the trial early because there were increased events, so it went completely the opposite way of that they were expecting. And then they looked at the reason why it didn't work out the way they thought it would, and the suggestion was that the recruitment had resulted in the recruitment of women that were too many years post-menopause. So in addition to the suggestion that perhaps this is advocacy for HRT lifelong once you start, what about when you start? Because you say there are lots of women not accessing treatment. The KEEPS trial, there's been some information that came out of that where they looked at the timing hypothesis of when you start HRT. And because menopause seems to go, if you're lucky, it's a year. If you're unlucky, it could be 7 years, 8 years that you're experiencing terrible, terrible symptoms. What about the timing?
Yeah, it's a great question. So if you look at WHI, the average age was 64. Lots of these women were overweight or obese, and as you know, a lot of them had cardiovascular disease, and they were given 2 milligrams of conjugated equine estrogen, so horse's urine estrogen that I don't use and I don't prescribe. But so even me, who clearly is very pro-HRT, would be really cautious of giving those women an oral preparation with a clot and stroke risk, with a synthetic progesterone, and that's the big key here, is the synthetic progesterone. Synthetic progestrogens have a cardiovascular risk, they have a clot risk, they also have probably a breast cancer risk. So you were giving they were giving the wrong type of HRT to the wrong women from the start. So we've got to realise that we're comparing apples with pears. You go forwards and we're actually giving transdermal estradiol, which stays as estradiol in the body, which is very anti-inflammatory. Oral estrogen gets converted to estrone, which is very pro-inflammatory. So the estrogen that we're producing from our fat cells is a very nasty pro-inflammatory type of estrogen compared to the estrogen that I'm getting from my patch. And also, the micronized progesterone doesn't have a clot risk, it doesn't have a stroke risk, doesn't have a cardiovascular risk, and it probably doesn't have a breast cancer risk. So then you look at, well, what about those older women? We see women who have had symptoms for 20, 30 years. And so those women have missed out, like you say, from WHI. If you give them transdermal estrogen, there isn't any known risk, but we don't know because the data hasn't been done. And isn't that frustrating? We've got all these women who want it. So, but if you look at the pathophysiology, if you understand how estradiol works, how can it suddenly decide at a certain age it's going to turn nasty on that woman? So we just use very low doses of transdermal estrogen. If they need progesterone, we give them micronized progesterone. And say to women, we don't know the data because it's not been done in this type of HRT, but I do know that even a low dose will help reduce your risk of osteoporosis and probably help your muscles and also reduce your risk of a heart attack. It might not, though, because we have got some data shows that it might increase. And women sit there and go, do you know what, I just want to feel better. But the other thing is about HRT, it's not a tattoo, it's not permanent, I'm not injecting them, I don't use implants. So a lot of women, they just say try it for 3 to 4 months and see how you feel. You are in control. When you stop, it's got a short half-life. It will be out of your system by the next day or 2. So you choose and see how you get on. And that's where shared decision-making, the nice guidance that came out in June last year on shared decision-making, I think are actually more important than the menopause guidance, to be fair.
I mean, I think you're quite right that the studies need to be done, but of course you have to recruit the women into those studies and they have to be willing to be recruited, and there's so much negativity around it. I think it would be quite hard to recruit for those kind of comparisons.
I don't think so, because there's about 13 million menopausal women in the UK, and the minority of women are on HRT. And our app users, we have 800,000 users. We've done no marketing on it. We've got no external funding for it. So I think there are a lot of women out there. We've got 30,000 patients who are desperate to do some studies with us, but we don't have any external funding. Pharma aren't interested in any funding any studies, and neither does anyone else, even the companies that are losing women from their workforce. So there's a lot of women that would want to be recruited. And what about women who've had breast cancer? 1 in 7 of those are just categorically told they can't have HRT. We don't know because we haven't done good studies. So rather than just saying no, we need to move forward with science, and that's where research is so crucial here.
I agree with you completely, but like you, it's difficult to get funding for it, and I think there's a bit of PR work to be done on convincing women that they do want to enter trials, and there is the issue that as you're your years as you go through your years of post-menopause, that your vascular function changes. There's endothelial dysfunction. There's lots of evidence that that's the case. And so there's a balance there. But definitely I agree with you that we need to do the trials. We just have to convince the women that they want to do them.
We're demonstrating live that there's much more to talk about than we have time for today, and plenty to take away with us. So I think it's probably about time to wrap up so we can change over for the next session. If there are questions that you had that you didn't get to ask, we'll find a way of collecting them from you.
Yeah, so from my perspective, I'm the Faculty of Pharmaceutical Medicine. Thank you particularly to our panel, brilliant. Thank you for your talks and your engagement, and thank you to the audience for being here and for your questions. As Anna said, we couldn't cover everything, but this is the beginning of saying, okay, where can we, as our organisations, best work together going forward?
Yeah, and thank you from me as well. I hope you agree it's been